From RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we're going to talk about a breakthrough for hands, ANZUPGO, which is the first and only FDA-approved treatment for moderate to severe chronic hand eczema. Our moderator this evening is Dr. Leon Kircik, who's the president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai in New York, adjunct clinical professor of dermatology at the Indiana University School of Medicine in Indianapolis, and medical director of physician skincare, DermResearch, and skin sciences in Louisville, Kentucky. Our speaker this evening is Dr. David Cotter, who is dermatologist in Las Vegas Dermatology, vice president and director of clinical research at Las Vegas Dermatology, and assistant clinical professor of medicine at the University of Nevada in Las Vegas. We'd like to thank our supporter, Leo, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the information will be displayed. If you're having technical issues, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in the browser and will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill it in and send it back to us. Within 1 to 2 days of this webinar, a certificate of attendance would also be emailed to you. Please submit your questions in the question chat pane on the right-hand side of the screen, and I wrote a note there so you can see exactly where to type in your questions for our faculty. So without further ado, I am going to pass the floor virtually to Dr. Kircik.
Thank you, Roxanne, and good evening, everyone. Welcome to another series of IDEF educational series. Before we go ahead tonight, I'd like to tell you a little bit of IDEF. And IDEF is a nonprofit organization, and our principal mission is to improve and raise awareness dermatology care all over the world through education, especially in underserved areas. And since COVID, we are addressing to our audience all over the world, not only in the US, but also in Canada, Southeast Asia, Europe, and South America, as you can see from some of our previous programs. Also, I'd like to tell you about to follow up with us on IDEF Derm at Instagram, at LinkedIn, as well as Facebook. Also, you can visit us at www.idefeducationalseries.com to register for all the upcoming educational events. Tonight, we have a very special program, very special guest, a good friend of mine, a great colleague, David Cotter, who's a dermatologist at Las Vegas Dermatology. He's a vice president, director of clinical research, and assistant clinical professor of medicine at University of Nevada in Las Vegas. And he's gonna tell us all about ANZUPGO, which is really the first and only FDA-approved treatment for moderate to severe chronic hand eczema. Welcome, David, and please take it from here.
Thank you, Leon, for that wonderfully warm introduction. It certainly is a pleasure to be with everyone tonight to talk about ANZUPGO, which is a breakthrough treatment for hand eczema. And in our practice, probably like yours, we like to say when you're ready for ANZUPGO, it's hands up, go. Let's go ahead and get it on your patients and get them treated, feeling a lot better. And tonight we'll get into the data that supports the utility of this incredibly amazing breakthrough medication for CHE. Let's start off just by examining this first slide, our title slide. Look at this chef. Here I am in Las Vegas, Nevada. We have some of the best restaurants in the world, and I see patients like her every single day, along with dealers and bartenders. And I think to myself, they can't do their job if they have chronic hand eczema. If there's inflammation in their hands that limits their ability to perform, there's nothing that can be done. Patients that come and see me can't wear gloves when they work on the strip. Just like in our world, if we had chronic hand eczema for ourselves, we'd have a difficult time performing our jobs jobs as doctors, PAs, and NPs. Same thing for a businessman or businesswoman that needs to shake hands to seal the deal. It's really hard to do that if you've got hyperkeratosis or fissures or weeping, oozing plaques on your hands, which is why it's with great pleasure that I'm excited to speak with you all about ANZUPGO tonight, because it's the first and only FDA-approved treatment for moderate to severe chronic hand eczema, or CHE. As we get into it, it's worth calling out that Leo truly is uniquely dedicated to medical dermatology. They have over 115 years of legacy healthcare and have reached over 100 million patients worldwide annually. They've got deep history in topical treatments. You may remember some of the amazing products they've had to help our patients with rosacea and plaque psoriasis, even before they launched Adbry, which we love for our patients with atopic dermatitis. They're bringing innovative biologics to market around the world, and they're present in 70 markets. Today, though, we're going to talk about ANZUPGO, or delgocitinib, a topical pan-JAK inhibitor for the treatment of chronic hand eczema in adults who have had an inadequate response to, or for whom topical corticosteroids are not advisable. The only limitation of use for this medication is that it should not be used in combination with other JAK inhibitors or potent immunosuppressants. Your other biologics used to treat atopic dermatitis are not considered potent immunosuppressants. If you remember, in the PIs for most biologic medications to treat atopic dermatitis, they specifically call out that these are not immunosuppressants. So really the only limitation of use for ANZUPGO is to not be combined with other JAK inhibitors. When I look at this slide, there's a lot to focus on, but the thing that excites me the most is over here in the bottom right-hand corner. No boxed warnings. That's amazing. This is revolutionary and ground-changing within the house of dermatology. If you think about it, it's a pan-JAK inhibitor. That means it inhibits JAK1, JAK2, JAK3, and tyrosine kinase 2, which is what's required to treat a broadly immune dysregulated disease state like chronic hand eczema. You have to attack it from multiple angles. But despite that, unlike other JAK inhibitors, including other topical JAK inhibitors we use in dermatology, there's no box warning. And as we get into today's deck, and specifically as we look at the safety data, you'll see why there's no box warning. This medication has no penetration enhancers, which means no propylene glycol or polyethylene glycol, so it stays in the skin. The bioavailability is extremely low, and there's no signal for any of those scary things that have been potentially attributable to JAK inhibitors in the past, which is why this medication has no box warning. Beyond that, beyond the safety that we can anchor to, it provides rapid and powerful skin clearance, quick relief from itch and pain. It has an incredibly favorable safety profile compared to the cream vehicle, and of course, it's steroid-free, which is so important because when you have chronic hand eczema, it's chronic, and we can't be chronically applying ultra-potent topical steroids or even medium-strength steroids. We've all seen those patients who come in and they've been using topical steroids for too long, and they already have atrophy, but they still have ongoing hand dermatitis. That's why we need safe topical medications that can be used long-term to get our patients under control. And sometimes long-term means months of continuous treatment, because with hand eczema, sometimes there's ongoing driving factors, whether they're irritant or allergic triggers that are perpetuating the patient's disease. When I was a resident, we had to learn all of the different types of chronic hand eczema. It could be atopic eczema, it could be psoriasis, it could be ACD, ICD, protein contact dermatitis. And sometimes we just didn't know. There were tips and tricks that might tell you, oh, if it's on this part of the hand, it's more likely this. If it's on that part of the hand, it's more likely that. But the reality is, in clinical practice, CHE is a multifactorial and heterogeneous disease that relapses over time. It's more than just atopic dermatitis. Certainly some of our patients with CHE have atopic dermatitis, but there's more to it than that. CHE is characterized by hand eczema that lasts for greater than 3 months or relapses twice or more per year. It's clinically distinct from AD with the multiple overlapping subtypes affecting the hands and wrists. So the symptoms our patients may experience are debilitating itch and pain. Hand eczema is distinct from atopic eczema in that often there's a strong pain component as well. The pain may be as bothersome as the itch, and in some cases, particularly cracked and fissured hand eczema, sometimes pain is the predominant symptom our patients experience. We see erythema, dryness, scaling, hyperkeratosis, and vesicles, and often patients have overlapping features. They may have more than one of these signs, all tied together. Here's some great examples of erythema, scaling, lichenification, edema, which can be hard to pick up. Hyperkeratosis, vesicles, or typical dyshydrosiform eczema or pumphalix, fissures. Imagine if you have a paper cut, how bad that hurts. Now apply that paper cut manifold all over both hands. Cracks and fissures hurt. They're very painful. And if you have enough inflammation in your skin when it comes to hand eczema that it reaches into the proximal nail fold and triggers inflammation in the proximal nail matrix, patients can manifest with nail dystrophy as well, which is very frustrating and very bothersome for them. As we look at the disease burden, we certainly know that it's a common occupational skin disease. And I alluded to earlier, I see this all the time in my service workers here in Las Vegas, whether they're performers, bartenders, dealers on the strip, or the folks that are cleaning your room. Those are hard jobs. When you guys come to town for fall clinical or DEF, there's a whole slew of people behind the scenes that help you have an amazing, incredible experience. And a lot of them do struggle with chronic hand eczema. And the trouble is, if your job requires you to be exposed to the risk factor that drives your disease, we know we can't control that. We know we can't avoid that, which continues to perpetuate this burdensome disease. And of course, we have limitations with long-term topical corticosteroid treatments, where some patients will have atrophy from their steroids and still have active disease. We need something better. We need something safe that can be used chronically. More than 50% of patients with CHE have one or more subtypes. We see patients with atopic dermatitis, ACD, and ICD, and certainly there are overlapping patient profiles. And what that means is there's different cytokine milieus that are driving this disease state in different patient populations. When it's AD predominant, that may be more Th2 and Th22. But if there's an irritant contact dermatitis component as well, there may be Th1 and Th17 cytokines, which gives you insight as to why some of our biologics we might reach for to treat chronic hand eczema off-label don't always control it. In fact, in some of these drug trials where they have dedicated data for hand dermatitis or hand atopic dermatitis, these are patients that were all patch tested, and anyone who's patch test positive was excluded from the clinical trial. If someone has allergic contact dermatitis, we don't always patch test them in the real world. And it's important to consider that as we pick our systemic therapies, because if someone has metal ACD, they may be more Th1 or Th17 predominant. If they're rubber and fragrance, it could be Th2 and Th22, which certainly limits the utility of some of our more specific agents. I mentioned earlier that ANZUPGO is a pan-JAK inhibitor, meaning it's able to inhibit signaling through JAK1, JAK2, JAK3, and TYK2. That's so important when we think about a broadly immune dysregulated disease state like CHE, because there's multiple different cytokines that could be driving this condition for our patients. Whether their CHE subtype is ICD, ACD, AD, or something else, we're able to cover that by inhibiting all four of our Janus kinases. And the wonderful thing about this medication is despite it allowing for broad JAK inhibition, it doesn't have a concerning safety signal, likely attributable to its low bioavailability and absence of penetration enhancers. This is a nice video that plays usually at our programs, but tonight I'm going to talk you through all of the data. So we'll go ahead and skip past that and get into the trial design here. ANZUPGO was rigorously evaluated in the largest clinical trials to date for adult patients with moderate to severe chronic hand eczema. We're talking about nearly 1,000 patients that were randomized 2-to-1 to receive either ANZUPGO cream on the one hand or vehicle cream on the other. And I mean that figuratively, because if you were ANZUPGO or you were cream, you got to use one or the other on both hands. Patients were evaluated multiple time points throughout the study, but the primary endpoint were the portion of patients that achieve an IGA for the chronic hand eczema scale of clear or almost clear with a 2-grade improvement at week 16. So the key secondary endpoints were at earlier time points, the IGA scores at week 4 and 8, as well as itch and pain reductions at week 2, 4, 8, and 16. Patients had to have CHE for greater than 3 months or relapsed for more than twice within a year. They had to have a baseline CHE score of moderate to severe and an itch score of 4 or more for a weekly average. They also had to have had an inadequate response to TCSs, or TCSs were medically inadvisable. Now, as we start getting into the patient demographics, I want to start thinking about the severity of their disease, because that's going to be very important as we look at the grading scale that was used in this study. First off, 28% of patients had severe disease. 72% had moderate disease. The baseline itch and pain scores were both right around 7, which is in the severe range. More than 40% had had greater than 6 flares during the past year, and almost all the patients had failed topical corticosteroids in the past. Nearly 1 out of 4 had 2 or more overlapping CHE subtypes at the start of the study. Mean age was 44, and there was a slight female predominance. Now take a look at the scale. It's important to unpack this, and maybe as we go through it, you'll even look at your own hands and try to decide what IGA you are at baseline. We can all agree what clear means. Clear means there's no signs of erythema, there's no scaling, hyperkeratosis, lichenification, edema, or fissures. Okay, perfectly normal hands. You might think you have normal hands, but after you go through the scale, you might decide, actually, you're running around mild at baseline. Maybe if you're like me, you're running around moderate at baseline. Now, severe, that's pretty easy to understand. It is severe. There's marked erythema, marked and thick scaling, marked hyperkeratosis and lichenification, and at least one of vesicles with erosion, marked edema, and 1 or more deep fissures. But as we start narrowing it down from severe to moderate to mild and almost clear, we see that there's a lot of overlap and room for potential interpretation. For example, almost clear. Barely perceptible erythema. Tell me what barely perceptible is. Well, when we do clinical trials, if I have to squint and try to decide, does the patient have it or not, that's what I consider barely perceptible. So to be almost clear, they have to have barely perceptible erythema and absolutely no signs of scaling, hyperkeratosis, lichenification, fasciculation, edema, or fissures. And that's where we get into a difficult area as we progress to mild. We're not in the barely perceptible realm anymore. We're in the slight but definite erythema. Slight but definite scaling. Slight but definite hyperkeratosis or lichenification. You have to have at least one of those. Plus at least one of the following: scattered vesicles without erosion, barely palpable edema, and superficial fissures. When I look at my hands, I see slight scaling and slight erythema right now. Go ahead and take a look at yours and see if you think you fit clear, almost clear, mild. When you get into moderate, we see these patients need at least one of the following: clearly perceptible erythema, clearly perceptible scaling. I'm looking at my hand right now, and you probably can't see this, but I have some right here next to my hair tie. Clearly perceptible hyperkeratosis or lichenification. And then you need at least one of clustered vesicles without erosion, definite edema, and fissure. So everyone just take a second at home, look at your hands, and try to figure out where you think you are, because that'll be very instructive as we start looking at the clinical trial data and the endpoints that are coming on the next couple of slides. As we get into the efficacy, we see that ANZUPGO provides rapid and powerful efficacy. Here we are looking at the IGA treatment success at both week 4 and week 16. At week 4, nearly twice as many patients are clear or almost clear with that 2-grade improvement. Coming in at moderate to severe, they're getting down from a 3 to a 4, all the way down to a 0 or a 1. By week 16, it's nearly 5 times as many patients are clear or almost clear, 29.1% versus 6.9%, meeting its primary endpoint as well as the key secondary endpoint with data as early as week 4. Patients also have improvement in their mean itch and pain scores. These are the proportion of patients that are achieving a 4-point reduction in their itch or pain. We see a quick separation from vehicle cream in both Delta 1 and Delta 2, with essentially overlapping line plots for Delta 1 and Delta 2, indicating that these are very reproducible results. In both trials, we see very similar results for our ANZUPGO treated patients. And even the vehicle cream seems to do well, indicating that this is a nice, intelligently designed cream. It's one with chronic hand eczema patients in mind. There's no fragrances, there's no irritants, there's no penetration enhancers, no propylene glycol either, which is a very common contact allergen that unfortunately many of our branded topicals do include. Now we're looking at the mean itch reduction and the mean pain reduction weekly over the 16-week trial. And we see that very quickly, within 1 to 2 weeks, we're having nearly 2-point drops in the patient's pain and itch scores, with on average a 4-point reduction being achieved in both groups by about week 10 or 11. If weekly pain and itch data is not good enough for you, here we are looking at daily itch and pain reduction. Let's talk about the itch first, over on the left. At baseline, let's say a patient's itch score was 7, 8, 9, 10, 6, wherever it was for that individual patient. That's recorded as their baseline. Then they get their first dose and they record the itch score for that day. Then they record the itch score for day 1, which is 1 day after they started initiation of the trial. And we see that very rapidly, even 1 day after the first application of ANZUPGO, we have nearly a 1-point drop in patients' itch scores. Similar for pain. By day 2 to 3, we're approaching that 1-point drop in patients' pain scores. So very rapid, very quick. Patients have a nice improvement in both their itch and their pain as early as day 1 after the first application. And now let's look at some patient cases, because I imagine you'll be as surprised as I was when I first saw the grading scale and what that means from a clinical trial outcome standpoint. Here we are looking at the left palm, and sure, this is obviously severe. There's multiple erosions, there's clustered vesicles, there's marked erythema. The patient has an itch score of 7.6 and a pain score of 7.3 at baseline. Now let's fast forward, moving a little bit along into the clinical trial. I believe this was at week 4. Here we are looking at an IGA of 3. That's already so much better. Let's go back to baseline. Fast forward just a little bit. This patient is great. This is a happy patient already in my clinic, but they're not at their primary endpoint yet. They still have an itch score of 6. Their pain score is 5.6. Now fast forward a little bit further. I believe this is at week 8 now. They're mild. They're down to a 2. This patient is a huge success, but at week 8 would be considered a clinical trial failure if the study was stopped. And if you look very closely and you squint, you can make out some areas of erythema and some edema and maybe 1 or 2 small vesicles. But now by week 16, the patient is completely clear. Their itch score is 2, their pain score is 0. And here's the difference between someone who's mild and someone who's clear, giving you a sense of the rigorousness of this specific CHE scale that was used in the study. Even a mild patient is extremely happy. That's clinically meaningful change for this patient, going back to where they were at baseline. So here's baseline, week 4, week 8, and week 16. So keep that in mind as we look through the rest of these cases today. Here's another patient coming in. My first thought is, wow, that looks severe, particularly when you look at that thicker lichenified erythematous scaling plaque towards the base of the palm. But overall, they're considered moderate with itch and pain scores around 6. Now fast forward a little bit, they're down to mild. This is a nice improvement. Their itch is 0, their pain is 0.1 at just 4 weeks. Here we are at 8 weeks, they're still considered mild. And at the end of the study, week 16, primary endpoint, they're almost clear. Not a lot of change between mild and almost clear. Clinical trial success versus clinically meaningful change. Our mild patients are still very, very happy. And getting at the idea of what's clinically meaningful. If you come into my clinic as moderate and you get to mild, you come in as severe and you get to mild, that's clinically meaningful. And so let's take a look at what clinically meaningful change means. Here's a patient that is only going to achieve a 1 grade improvement. Here we're at baseline, widespread erythema, multiple vesicles, even a few scattered fissures. IGA 3, pain and itch, riding right around 8. Fast forward 4 weeks later, this patient is now mild. There's still a lot of fissures. There's still a lot of pain. They're still having a lot of itch. Fast forward to week 8, they look a lot better, but they're still having a lot of itch and a lot of pain. By week 16, though, look at these patient-reported outcomes. Itch and pain are down to a 2, but the patient is still mild. And it goes back to the rigorousness of the clinical grading scale, because there's still some perceptible erythema. Maybe there's some areas of edema, maybe a few vesicles. But to go from here at baseline as a moderate to a mild, still mild, still mild, gives you an idea of the rigors involved in achieving clear, almost clear, and why a patient who gets to mild would still be considered a clinically meaningful result. And here we are looking at the ANZUPGO efficacy across all subtypes of CHE for the number of patients that get to clear, almost clear, or mild. So this is including anyone that would have that clinically meaningful one-level change, a moderate patient that gets to mild, for example. And we see that across the board, nearly 50 to 75% of patients achieve clinically meaningful results, whether they have primarily ICD, ACD, atopic hand eczema, hyperkeratotic hand eczema, or vesicular hand eczema. Patients do extremely well. We do see that the hyperkeratotic subtype is numerically lower than some of the others, but not statistically lower. And we know that that is a more historically difficult to treat disease state, and partly because it's hyperkeratotic. It's just thicker. It's harder to get to clear or almost clear when you have hyperkeratosis. Now, after the initial 16 weeks, patients were able to go into the open label extension. They were transferred to Delta 3. 801 patients continued into that, and they were able to use ANZUPGO cream BID as needed for 36 weeks. At any point, they got to clear, almost clear, they could stop it. If they got their IgA back over mild, they were advised to resume it. And here we are taking a look at the proportion of patients throughout the 36-week open label extension that achieve IgA 0 or 1, clear or almost clear. Our solid green line are patients that had been previously on ANZUPGO during Delta 1 and Delta 2, so the 16-week vehicle-controlled portion of the trial, and they come in and they're doing great. They rock and roll with 20 to 30% of them at any point in the trial achieving clear or almost clear. For the vehicle patients, by about week 4, they catch up to the continuous ANZUPGO patients with a nice, even, steady improvement, controlling their disease all the way up to week 32. And there's a nice little bump here at the end, going from week 32 to week 36 that may have to do more with the way trials are done than anything biologic. Now let's talk about safety, because this is a JAK inhibitor and patients are going to ask, and they're going to Google JAK inhibitors and they're going to hear about the boxed warning. And is that relevant for ANZUPGO? Well, I'll start off by saying that the FDA doesn't think so, because there's no boxed warning. Beyond that, there's no drug-drug interactions, there's no contraindications, and there's no required lab monitoring to start or to monitor the patients. Taking a deeper dive at the safety specifically, and this is the wildest thing I've seen in a long time. This is our entire safety slide. Think about that for a second. This is our entire safety slide. There's no big safety tables of scary things that happen because they don't happen on ANZUPGO. Here are our 2 safety boxes. First of all, when we look at all AEs, the rates for ANZUPGO were 0.5%. On the vehicle cream was 3.4%. Turns out if you don't treat someone's chronic hand eczema, they might still have symptoms. There was a very low rate of application site paresthesia and pain for ANZUPGO cream versus vehicle. They were mirrored 0.5 versus 0.6% for pain, 0.6 versus 0.6%. As we take a look more granularly at the safety profile, the FDA asked Leo to include in their promotional slide deck, which we're doing right now, all of the adverse reactions that are reported in less than 1% of subjects. Usually a clinical trial safety table includes all of the AEs that occur in greater than 1% of patients, but for here we're talking about less than 1%. And because there's so few, I'll just read them. Application site pain, well, we just saw that was 0.6%. Paresthesia, we saw that was 0.5%. Pruritus, erythema, and bacterial skin infections, including finger cellulitis, paronychia, other skin infections, leukopenia, and neutropenia. Now, mind you, there were 800 patients that entered into the open label extension. And so if you followed 800 patients over the course of first 16 plus then 36 additional weeks, so 1 year, we're talking about less than 8 patients out of 800 having any of these scary things. Furthermore, there were 1 case of eczema herpeticum, which was outside of the treatment area. They didn't discontinue treatment with ANZUPGO, and they did fine. There were 2 cases of herpes zoster, so 2 out of 800 people treated over the course of a year is much less than 1% and very similar background rates. And that's it. That's all we have for safety data. And we get right into the ISI, which is really clean. There's no boxed warning. There's a call out for 1 patient developed a basal cell on the head and neck while he was being treated with ANZUPGO. Good thing we're dermatologists. We know how to handle that. Serious infections, we talked about the eczema herpeticum and the cases of zoster. Just like any other medicine, we recommend complete age-appropriate vaccinations and avoid live vaccines immediately prior to, during, or immediately after ANZUPGO treatment. There's this call out for the potential risks related to JAK inhibition, but there's no boxed warning. We talked about the AEs that occur in less than 1% of patients, and there's no meaningfully data that we can extrapolate for lactation. So what's recommended is if a mother who's nursing is using ANZUPGO, it's recommended that she avoid direct contact with the nipple and surrounding area immediately after applying ANZUPGO to the hands or wrists. So what that looks like in my practice is if I've got a mother who's nursing and needs to use ANZUPGO, I say, go ahead and put it on, wait 15 minutes before you go and you touch the area that the baby's going to be nursing from, just to be extra cautious. But I don't have any concerns about using it in that nursing mother. We just give them those pieces of information. So how do we do it? It's easy. Apply a thin layer to clean and dry skin twice daily to the affected areas on the hands and wrists. Dosing is easy. Make sure your patients are vaccinated if they need to be, and avoid live vaccines. Don't use more than 30 grams per 2 weeks or 60 grams per month, which would be really hard to do applying it to just the hands and wrists. We like ANZUPGO, which is why we say, hands up, go. When someone walks into my clinic and they've got a rash on the hands that's been there for a couple of months, maybe it's been on and off, it's been recurrent, I'm reaching for ANZUPGO because I always want to offer my patients the latest, the greatest, the best in market, and that's what ends up. It's the first ever medication on label for chronic hand eczema. No longer do we have to write off-label medicines. Do we have to reach for topical steroids? We can write an on-label product for our patient's disease. We can get everyone closer to a disease and a drug matched up every single time. And it feels nice. If you haven't tried it, grab a sample or a vehicle cream from your rep and ask to see how it feels. It's definitely non-greasy, and of course it's steroid-free. I love this as someone who does a lot of patch testing. There's no propylene glycol. I see a lot of patients that come in and they're referred to me for refractory dermatitis, and it's because they're allergic to something in their topical preparations. Sometimes that's propylene glycol, sometimes that's the topical corticosteroid itself. But in either way, this product has neither. No topical steroids, no PG, and also no polyethylene glycol. There's no sensitizers or irritants. There's no parabens, there's no perfumes, there's no fragrances, and it has an extremely low bioavailability of 0.6%. There's great access and savings programs. In our practice, pretty much every commercial patient gets it for $0. So we write it for anyone who walks in with hand eczema. There's a great ANZUPGO copay program that allows those patients to pay for as little as $0. And they've got the ANZUPGO Let's Go, which is the patient assistance program for those with financial need who are uninsured or underinsured. They may be able to receive ANZUPGO through the patient assistance program. So that's why when I see a patient with a hand rash, I reach for ANZUPGO. If it's chronic hand eczema, I want to write an on-label medication that first and foremost is extremely safe with no boxed warning. You saw those safety slides, absolutely insane that we call out all the things less than 1%. And even doing that, it was still a very short list that provides rapid, powerful skin clearance. Think about that clinically meaningful change occurring in nearly 3 out of 4 patients in your clinic have clinically meaningful change when you put them on ANZUPGO. Provides quick relief from itch and pain with data as early as day 1 after application, and a very favorable safety profile. It's having a pan-JAK inhibitor, the efficacy of a pan-JAK inhibitor with the safety of a vehicle. And of course, steroid-free topical formulation for the hands. And with that, thank you so much. That's all that I had, but I'd be more than happy to answer any questions for anyone who may have some on the line.
ANZUPGO, that was great. That was
Thanks, Leah.
great, David. Thank you so much. I learned a lot. So we have a bunch of questions. One is, what's the greatest challenge that when you're diagnosing or managing patients with CHE, right? In the old days when I was young, I used to biopsy. Is this CHE? Is this psoriasis? I don't know. And the answer is always psoriasiform dermatitis. So I stopped. I hate it. How do you manage? What do you do?
You hit the nail on the head, Leon. That's such a fantastic question. And what I learned from my dermatopathologist when I was a resident at UCSD many moons ago was that if you can't tell it with your eyes, he can't tell it with his microscope. And so I haven't biopsied hand eczema in a long time because usually if you can't tell, neither can your pathologist, and you get psoriasiform spongiotic dermatitis like you just described. So clinically, it's actually a pretty simple diagnosis. Patient has a rash on their hands and it's recurrent or chronic, boom, you have chronic hand eczema, which can be one of typically 5 etiologies like we talked about: AD, ACD, ICD, psoriasis, and of course sometimes protein contact dermatitis, maybe some other things to round out the differential. But the nice thing with a medication like ANZUPGO is you have that broad immune regulation by hitting all 4 JAKs. And so now we don't really need to sort out the exact etiology, although it's good to look at your patient holistically and take a look and see, do they have scalp psoriasis? Do they have typical antecubital fossa AD? But the reality is, even if there's one thing that you see somewhere else that gives you a diagnosis, often there's 2 or more subtypes going on in any individual patient. So now I say, you've got a rash on the hands, let's try ANZUPGO.
Another question is about the efficacy data that, what's the most important, you presented quite a bit, and what's the most important, what most influences your perception of the efficacy of this drug? I'm gonna be biased and I'm gonna say no box warning to me is the most impressive thing that has happened to a JAK inhibitor, right? In dermatology, I should say. But the question is really about the efficacy. Tell us, what do you think it was the most important point?
I absolutely agree with you about the no box warning. I always anchor to that because safety is so key for a chronic disease state like CHE. When I think about the efficacy, what I like the most is actually the rapid improvement in itch and pain. Often what brings patients into our office is not so much the appearance. They've been struggling with that for a long time, but they're fed up with the way it feels in their skin. So being able to give them something that rapidly improves their quality of life, helps them feel better, also buys compliance. When something feels good, doesn't burn or sting, and is making you feel better, you want to keep using it. And I always counsel my chronic hand eczema patients, this medicine is different. This medicine is your marathon medicine. You're going to keep using this for a long time. You're going to use it as long as you need it to get to where you need to be, whether that's clear, almost clear from a clinical trial endpoint, or a clinically meaningful endpoint, at least getting to mild disease, which seems to correlate very well with those patient-reported outcomes. I tell patients it's not like that steroid you've used before that might work really fast, but then you got to stop it. We can keep using this as long as you need it.
We have an interesting question. So if the patients who had patch tests were excluded in the study, is it recommended to do patch tests prior to starting treatment?
Oh, this is such an important question. All of the patients in the LEO studies were patch tested, and if they had ACD, they were still allowed into the study. And nearly 20% of the patients in the ANZUPGO trials actually had allergic contact dermatitis, which is powerful because now you know that even if someone has an ACD component, they're included in these data sets, they can do well. What I was alluding to is actually in some of the other drug trials for biologics that have dedicated hand and foot dermatitis studies, those patients were patch tested as a entry criteria, and if they had ACD, they were excluded from the study. And so now we've got something that in the real world, no, you don't need to necessarily patch test every patient to predict how well they'll do. If you think someone has ACD, you can still use ANZUPGO because those patients were not excluded from this trial, which is very different than some of the other medications out there.
So really, to summarize, the whole point is that the biologics that were tested in hand dermatitis were only for patients who had atopic dermatitis with the hand dermatitis. So that's why all the allergic contact was excluded. But in this case, this drug included everybody.
Exactly, which is so great for patients because we do a lot of patch testing. It's fun for us, but it's not always fun for the patient.
Exactly. This is really a good one. What ICD code to get it covered?
So we coded as rash, atopic dermatitis, dermatitis NOS. We put in a lot of different ICD codes, and I always ask our pharmacy colleagues and actually some of our contacts from the company, what's getting the most pull through, and that way we can modify our code. So that way our click corresponds to what needs to go through.
And probably this is gonna change from locality to locality, right? All the politics are local, all the insurance coverage is local, so only God knows. Is there a patient support program available? I think the answer is yes, right?
Yes, there is. Patient assistance program as well as copay cards. Most commercial insurance patients get it for $0.
Perfect. How about what additional data, if any, would you need to feel confident prescribing ANZUPGO?
Well, after going through the deck, Leon, I don't need to see any additional data. We've already demonstrated that it's effective, it decreases pain and itch, and it's extremely safe, which are all of the things that I want. When we look at a drug holistically, it needs to have a great value proposition for our patients, and this one does, because it's safe, effective, and has good access for our commercially insured patients.
Perfect. I think that's the end of our questions, and we are happy that we are able to finish early thanks to Dr. Cotter, and we'd like to thank Leo Pharma again to support this program to make it happen. And now that we are done with Leo Pharma program, our next program is on November 25th at 7 p.m. Dr. Naim Isa, and he's gonna tell us all about understanding IL-17 biology across disease states. It is actually a non-promotional program. It is a very different program that we will look into IL-17 across disease states. I thank you so much for joining us. Have a good night, everyone.
Thank you. Good night.